So before I present our faculty for this session, the session is entitled Understanding Lambert-Eaton Myasthenic Syndrome and its association with small cell lung cancer. I want to turn your attention to the screen. Now you will see find a QR code. Please take a moment to scan the code or to go to the URL listed on the screen so that you can participate in the pre-session survey about the content you're about to hear in this session. These questions are completely anonymous, and your answers will help our team to tailor further educational programming to your needs. We really appreciate your presentation. And so I'm going to give people a moment to answer the pretest things. So, sorry, I see some ready to come up, but I'm going to give people a moment or two to fill that out. Okay, so now I think you've had enough time to hopefully do the pretest. Or at least finish it while I'm still talking. And I'd like now to acknowledge this session is supported by an independent educational grant from Catalyst Pharma, and I'd like to introduce and welcome to the stage our faculty for this session, Dr. Jennifer Carlisle.
All right, thank you so much. I'm an assistant professor at Emory University, and this is my first time here at this conference, and it's been a huge pleasure and really an honor to get to speak with such distinguished faculty on the agenda. These are my disclosures. So we're going to talk about the pathophysiology and unmet needs associated with LEMS, or Lambert-Eaton Myasthenic Syndrome. Make sure we understand and are capturing the patients with this disease and assess the mechanism, safety, and efficacy of therapeutic options. So welcome back to pathophysiology, biology, med school, whatever your flavor of science class was. I have to say I learned a lot preparing this talk. First, let's remind you how the normal neuromuscular junction works. An action potential will come down the nerve terminal and stimulate the influx of calcium via the voltage-gated calcium channels. This triggers release of acetylcholine-filled vesicles to migrate to the nerve terminal, fuse with the active zone, and enter the synaptic cleft. Acetylcholine subsequently binds to nicotinic receptors that triggers the opening of ion channels that allow the influx of sodium and thereby propagate the message down through the muscle. So there are two big pathologies of the neuromuscular junction, and we are more familiar with myasthenia gravis. It is 10 times more common than Lambert-Eaton, and they have some similar features and some opposite features. Myasthenia gravis worsens with activity and improves with rest. Patients notice first a lot of bulbar weakness symptoms like ptosis and diplopia, changes in facial expression, difficulty swallowing, and really extremity weakness, shortness of breath happens later on with more severe disease. Myasthenia gravis affects the postsynaptic terminal with antibodies against the acetylcholine receptor on the motor end plate, whereas Lambert-Eaton is an IgG antibody-mediated cross-linking of the voltage-gated calcium channels in the presynaptic terminal, thereby reducing the release of acetylcholine into the synaptic cleft. So symptoms of Lambert-Eaton actually begin with proximal leg weakness, and patients and practitioners can notice this with difficulty in the patient rising from a sitting position. I have Dr. Langer presented some of this information before and astutely mentioned, noticing if a small cell lung cancer patient has been doing well in therapy, but all of a sudden comes into clinic in a wheelchair, this may be a red flag to start screening for some of these paraneoplastic syndromes. You can see areflexia in the absence of significant muscle atrophy, but after facilitating the muscle or doing some quadricep extensions, you can re-elicit that motor movement or obtain a reflex then. Patients have oculobulbar weakness. Up to 70% will complain of ptosis and diplopia, which is an overlap with myasthenia gravis. A distinguishing feature is autonomic dysfunction. So nearly all patients will report dry mouth. Men will have erectile dysfunction. You can see constipation, orthostatic hypotension, and altered perspiration. And respiratory failure is a very late side effect, but a confusing one in lung cancer patients. So of all Lambert-Eaton cases, and this is a rare disease, 50 to 60% are associated with small cell lung cancer, and this reflects the smoking population, which are usually median age of onset of 60, majority male, and obviously a heavy tobacco use. Prospective reports have said anywhere from 2 to 3% of small cell lung cancer patients can get Lambert-Eaton. And the remaining 40% is non-tumor LEMS, and this, like other autoimmune conditions, has two peaks, one in the early 30 years and a later one after 60. It's slightly more female predominant and associated with HLA B8DR3, a haplotype linked to other autoimmune conditions. So they were able to find that LEMS is an autoantibody to tumor voltage-gated calcium channels by injecting mice with IgG collected from patients, and you can recapitulate the symptoms of LEMS. Conversely, they were able to show by injecting IgG from LEM patients into cell cultures of small cell carcinoma cell lines, you could see significant, really reduced calcium influx there. So what do you do in the clinic? You need to do a good neuro exam, and this may or may not be done by the oncologist versus the neurologist. Like I said, you can elicit this lack of patellar reflex, then quadricep contractions, and the reflex will return for a few seconds. Our neurologist will do nerve conduction tests, which show small compound muscle action potentials that improve with facilitation or exercise. The EMG is a little more variable, just showing muscle jittery action potentials. And the gold standard outside of the physical exam findings is now serology, looking for antibodies specifically against the PQ subtype of the voltage-gated calcium channel. And these labs are a part of broad paraneoplastic panels that are available on most of our healthcare electronic medical record systems. So what do you do? This may not be for us, but when you find Lambert-Eaton first, a lot of this work comes from Dutch researchers, and they looked at a cohort of 100 patients diagnosed with Lambert-Eaton in neurology clinic over a span from 1990 to 2006, and then they screened patients to see how many patients could they find a malignancy in. And in this cohort, tumor preceded diagnosis of LEMS, and 7% tumors were detected within 3 months after diagnosis, and 91%, and within 1 year, and 96%. And overall, they found that proportion around 50 to 60% of LEMS cases were associated with small cell lung cancer. This led to the design and validation of a prospective score called the Delta P score, and they came up with a handful of markers to help calculate a 0 to 1, present or not, that can give neurologists or primary care clinicians a probability of detecting small cell lung cancer and then guide screening efforts. So first is dysarthria or dysphagia. E stands for erectile dysfunction, so only a male point for that one. Weight loss, tobacco use at onset, age greater than or less than 50, and performance status cut off of at 2. And you can see with 0 to 1 of these points on the Delta P score, you have almost no likelihood of having small cell lung cancer. There's a tipping point between 2 and 3 where the likelihood becomes much, much greater. And this helps determine how frequently screening needs to be done when we find Lambert-Eaton myasthenic syndrome before the malignancy. What is the prognosis and treatment options? Here's a small study looking at 15 small cell lung cancer Lambert-Eaton patients with 5 or 6 lung cancer without Lambert-Eaton matched controls, and they were matched for sex, age at lung cancer diagnosis, limited versus extensive stage, and treatment, and they found a median overall survival in the setting of having this autoantibody-driven syndrome was higher at 17.3 months compared to small cell lung cancer patients without Lambert-Eaton at 10 months. And in patients where their diagnosis is identified by having this syndrome, there of course may be a lead time bias. As a medical oncologist that likes working with the immune system, I do think there also may be immunologic differences. And I want to mention for those of you that may not treat a lot of small cell lung cancer patients that we can develop an immune-mediated adverse event that looks like Lambert-Eaton and is associated with voltage-gated calcium channel antibodies. I found a handful of case reports, a melanoma patient on Pembro who had the classic waddling gait and dysphagia. So exam findings and testing proved this syndrome, and they had marked improvement with prednisone and pyridostigmine. A small cell lung cancer patient, not surprisingly, developed this both symptoms and antibodies, which improved with steroids, IVI, and IVIG, and a squamous cell carcinoma lung cancer patient who had nerve conduction studies, antibody testing, and improved with pyridostigmine and the now FDA-approved treatment option, which I'm going to talk about next. So there's a couple classes of therapeutic interventions we have to manage LEMS. Acetylcholine esterase inhibitors like pyridostigmine form the basis of management in myasthenia gravis. And this increases the availability of acetylcholine by allowing it to stay in the neuromuscular junction longer. Potassium channel inhibitors like amifipridine or 3,4-diamyopyridine is what I'm going to talk about next. And this inhibits potassium channels at the presynaptic terminal, which prolongs the action potential and helps the currently open calcium channels stay open longer to stimulate the release of more acetylcholine. For critically ill patients, we need fast-acting short-term therapies to remove or neutralize antibodies like plasma exchange, plasmapheresis, IVIG. And long-term therapies, obviously in small cell lung cancer, we need to treat the underlying malignancy. In patients with non-tumor associated LEMS, they may receive immunosuppressants like azathioprine, mycophenolate, cyclosporin, or rituximab. So amifampridine was approved based on 2 studies, which because of the rare nature of this disease are small. Here I'm showing the phase 3 randomized double-blind placebo-controlled withdrawal trial in 26 patients. So these patients were on therapeutic doses, which range anywhere from 30 to 80 milligrams per day, divided in 3 to 4 time daily doses. And they've been on an optimal dose for at least a week, and then they randomize which patients have to stop the drug and go on placebo. And you can see that when they measured the primary endpoints of this quantitative myasthenia gravis score and a subjective global impression, patients did much worse when they withdrew from amifampridine. This drug is well tolerated. There are contraindications if you have a history of seizures. They did see a few hypersensitivity reactions. You do need to up-titrate the dose. The starting dose may be 30 milligrams daily if you're over 45 kilograms, but you can get up to a dose of 80 milligrams total per day. They saw paresthesias as the #1 side effect. Upper respiratory infections and then GI complaints like abdominal pain, nausea, vomiting, and diarrhea were common. Some mild elevation of liver enzymes, but for the most part, very well tolerated. So kind of backing up and thinking about our clinic, what do we do in a cancer patient sitting in front of us who we find Lambert-Eaton myasthenic syndrome in? Well, if they're limited stage, currently, it wouldn't really change our plan, which is proceed with definitive curative intent chemoradiation. But as our NRG trials looking at adding immunotherapy into the limited stage setting read out, we may need to consider whether or not we're going to use immunotherapy in those patients. And I did, read a pretty astute consideration in this potentially curative patient population is if they already have other paraneoplastic issues such as a sensory neuropathy or encephalitis, this may kind of sway us even further to whether or not to do PCI in this patient population. But what about extensive stage small cell lung cancer? And I'm sorry I just wrote atezolizumab because I had a patient that I had to consider this in before the Caspian trial, so I should say atezo or durva. But should you give immunotherapy in patient with an autoimmune complication from their disease? And this really, I think, remains a case-by-case basis in a setting where we don't have a lot of data, depending on how well the patient's symptoms are controlled, especially now that we have a approved therapy specifically for symptoms, whether or not they're on immunosuppression, what their performance status is. I had a patient with non-Lambert-Eaton, but more of a dementia-type paraneoplastic syndrome associated with her small cell lung cancer, and this was so debilitating at home, so hard to deal with, are still on steroids, that this patient and her daughter, who was her primary caretaker, did not want to take the risk of worsening anything about her neurologic condition, so they opted to just do chemotherapy for her disease. And there are definitely case reports of safe administration after discussion of risk. We all know the stakes are very, very high for extensive stage small cell lung cancer, and I think many patients and clinicians would feel like it's worth trying to push through and see if we can manage symptoms to have a chance at more long-term control. Just a couple of other things to think about. There are a bunch of other paraneoplastic syndromes in small cell lung cancer. SIADH is pretty obvious with a very low sodium, inappropriately concentrated urine osmolality. I'm fortunate that I have a dietitian that helps manage patients and follow-up labs for this on a very regular basis across lung cancer patients. Cushing syndrome or ectopic ACTH, subacute cerebellar degeneration has associated ataxia and dysarthria associated with anti-Yo antibodies. Encephalomyelitis, which my patient had before with an anti-Hu antibody, where you can see confusion, obtundation, and dementia. There's a sensory neuropathy, which can be very debilitating, and probably one of the rarest ones, opisthoklonus myoclonus from an anti-RI antibody, can lead to cerebellar degeneration and ataxia. So now that we have the availability to order these broad panels and need to probably do it in more of our patients, what might we find? Here's a series of 116 patients at Mayo who had pathology-confirmed small cell and blood to look back at serologies for. 41% of these small cell patients were limited stage, which is not, our normal presentation. They documented paraneoplastic symptoms of one sort or another in 61%, and you can see the column on the left showed patients with neurologic manifestations, and the column on the right, those without neurologic manifestations. And higher up on the list, those autoantibodies found were more likely to be associated with symptoms compared to some of the other, autoantibodies that were found without symptoms. So if we do look at more patients, we're going to find more of these. I think we're under, identifying it. And specifically for Lambert-Eaton myasthenic syndrome, I know this is very hard to read, but hopefully the QR code will work. There was data presented just at World Lung this year, a couple of weeks ago, that looked at kind of a database of billing and coding data for small cell and Lambert-Eaton and found, at least using that rough measure of incidence, much less patients were identified than would be predicted based on the small cell lung cancer expectation or population. So please take a look at that. Here's my final slide. I just wanted to remind everyone that oncologists need a high index of suspicion in lung cancer patients who develop proximal muscle weakness, autonomic dysfunction, et cetera. To do more neurologic evaluation, we can order antibody panels and ask for urgent neurology consults, which may or may not be easy to get. Neurologists need a high index of suspicion of underlying small cell lung cancer to continue imaging based on the delta P score. We need to be watchful as return of symptoms and patients that respond to their treatment of small cell lung cancer may herald relapse. Conversely, you can fully treat a patient and they can have persistent paraneoplastic syndromes despite well control of their disease. And a reminder that we can see crazy things with immunotherapy, and autoimmune-mediated adverse events can include this particular flavor. Thank you.
So thank you very much. We have time for some questions, certainly. And one question is this something where you think that practitioners are just sort of chalking things up to decline, or is it so specific that you think that people are pretty clear that this is something where they need to see a neurologist, and be referred for further assessment?
I think the first, we all see small cell lung cancer patients decline with progression of disease, and it's very easy to blame this, high burden, quickly growing malignancy, often with brain mets. In kind of preparing for this talk, I just, I think back, there's probably a few I miss. As rare as this is, I see enough small cell lung cancer patients. I know I've missed this in the past. So it's definitely heightened my, lowered my threshold to really look into it more.
And, when this sort of has come up in the clinic, my sense is that, that there's this whole panel of antibody tests that you can order, and then when they come back, you still don't know what to do with them. Is this a clear-cut diagnosis for a neurologist, or not necessarily?
Again, I'm in the med school line of training of see one, do one, teach one in terms of this topic. So I do think a very focused, considerate neurologic exam, a good neurologist will identify the lack of reflexes and improvement with facilitation even without needing more advanced testing. So I think for a neurologist, this is a little bit more of a slam dunk than it is for a medical oncologist. That being said, this has prompted me to order a similar panel on the inpatient setting where we see people come in acutely weak after immunotherapy, and I say, this doesn't quite fit, and I get the blood drawn before neurology is able to kind of commit to what's going on. So I do, having something kind of more up in the front of your mind really helps us identify rare things, and we're not going to find it if we don't look for it.
So one additional question I have is that, so as some of the people, particularly the Californians, have mentioned at major academic centers, in my practice, I see more sort of transformed small cell lung cancer from largely EGFR mutation positive patients than de novo small cell. Is that a group that can get this, or do we not know?
I don't think we know the answer to that at all, and that would be an interesting patient population to do more upfront plasma screening.
Yeah. Dr. Langer?
You showed some interesting data for detection, I think, which was presented as a poster at ASCO, World Lung. It seems to me that at best, we're detecting maybe 10% of all cases, or perhaps even less than that.
Yep.
And I guess considering the common coexistence of paraneoplasia with small cell, I wonder if we shouldn't just get a panel at the beginning so we know what's brewing. Not necessarily restricted to the VGCC antibody, but really going through the entire list. Our patients are so, they come in feeling tired or weak. It's hard to necessarily discern neurologic symptoms from just generalized weakness. And of course, both the disease and the treatment we give can induce side effects, particularly with immunotherapy. We can see weakness, we can see myasthenia-like syndromes. I think I've seen at least one case of Guillain-Barré type presentation, but maybe I'm wrong. Maybe it's the underlying paraneoplasia. So What do you think of initiative where we're doing that? The small cell is so generally debilitating, and it may not just necessarily be the cancer. And there are certainly cases where patients seem to be doing well radiographically, but they're doing terribly clinically.
I agree. I feel I see my small cell patients kind of teetering on a cliff, and any one thing can help. You can tip them over, and we need to capture more hooks to pull them back on land so we can treat their disease.
And you mentioned the sort of individualizing the question about immunotherapy. Do we know if immunotherapy makes this worse, or do we just not know?
I was only able to find case reports and some people reporting positive outcomes. Not Lambert-Eaton, but I know of lung cancer patients with myasthenia with stable disease for 10 years, not on any treatment. They get IO and are intubated for a month. So it's still risky, but it's something that I think in small cell we have enough reason to need to push forward, and we obviously need as a group to collect more data.
Sounds good. And I think the last question that I have here is obviously, we're talking about paraneoplastic syndromes and our, we're used to also seeing those with other thoracic malignancies, squamous cell being the most common. Is this really restricted to small cell? Is that where we should be looking for it, or do you see this in some other?
Found that one report in a squamous cell lung cancer patient, and I do think there are a lot of similarities in those two groups because of the heavy smoking burden. I think we need to focus on small cell because of their incidence of all the other paraneoplastic syndromes if we are going to do more upfront kind of broad-based panel screening. But we're all seeing more antibody-mediated complications with immunotherapy, and it's something to think about. Okay,
great. So I don't see any more questions on my iPad here, and so unless there are any more questions, I think that at this point I'd like to thank you for an excellent presentation. But we also would like for people to take a moment to participate in the post-session survey by scanning the QR code. It is up there, or going to the URL listed on the screen. The survey is anonymous, and we greatly appreciate your participation. I'll wait a couple minutes to make sure that everybody has a chance to do the post-test. Okay, and so again, for those of you, if you can make sure you work on the post-test, and we actually are going to be in a situation where we're ending, I think, about 15 minutes.